Hello, and welcome to the Clinical Care Options Oncology podcast. I'm your host, Ryan Topping. In today's episode, we are joined by Dr. Matthew Davids from the Harvard Medical School and Dana-Farber Cancer Institute in Boston, Massachusetts, Dr. Lindsey Roeker from the Memorial Sloan Kettering Cancer Center in New York, New York. Together, they will be discussing BTK inhibitor resistance and how this shapes treatment choices for patients with CLL. This episode is part of a larger educational program entitled A Cancer Conversation, Optimizing the Care of Patients with CLL through a Deeper Understanding of BTK Inhibitor Resistance. For more information on Dr. Davids or Dr. Roeker, along with a link to the complete program, including a CME certified text module, downloadable slide set, and clinical thought commentary, please visit the show notes for this episode. Now, let's hear what the experts have to say on this topic.
So thank you so much for joining us today. Today we're going to be talking about a cancer conversation and optimizing the care of patients with CLL through a deeper understanding of BTK resistance. My name is Lindsey Roeker, and I am an assistant attending and CLL Program Director at Memorial Sloan Kettering Cancer Center in New York City.
And I'm Matt Davids. I'm the Clinical Research Director in the Division of Lymphoma at Dana-Farber Cancer Institute and an Associate Professor of Medicine at Harvard Medical School here in Boston.
And we're thrilled to be chatting with you about BTK inhibitor resistance, how we think about it, and how we should use these data in informing our practice. So we're going to take it through kind of two different sections. The first is looking at first-line therapy for CLL. How do we think about BTK inhibitors in this setting? And then the second section will really focus on second-line or later lines of therapy, and how do we think about BTK inhibitor resistance in the relapse refractory setting. So to kick it off, let's think about our current options for patients with CLL who are needing their frontline therapy. So Matt, when you're meeting a patient who's showing signs that they need to be treated, what kind of testing are you doing at that point, and how are you thinking about kind of that approach?
Yeah, I think that's a great place to start, Lindsey. We send a pretty comprehensive genetic profile before we start treatment on our patients, and this includes FISH testing to look for the characteristic cytogenetic abnormalities. In particular, we're looking for deletion 17p, which, as you know, is a high-risk form of CLL. Then we look at the IGHV mutational status, which we know can be either mutated or unmutated, with the former being a more indolent form of the disease and the latter, the unmutated, being somewhat more aggressive. And then we also send a next generation sequencing panel at time of starting treatment, and that's mainly to look for TP53 mutation, which when mutated is another high-risk form of CLL. And as we'll see as we talk about the different treatment options, particularly these high-risk abnormalities do influence the optimal choice of frontline therapy. Next generation sequencing panel does include a variety of other genes, which I'd say are a little bit more niche right now in terms of their significance in practice. So I think if you're not seeing that much CLL, really just focusing on that TP53 mutation test is really the key one.
And Matt, when you're meeting a patient and talking to them about their options for their frontline therapy of CLL, how do you present these options, and what features are kind of pushing you one direction or the other?
So first of all, I do always like to mention clinical trials because we always have things that we can learn in CLL, even though we do have many effective therapies now. But as I kind of focus in on the standard treatment options, it's really right now between two main options. So one would be continuous treatment with a covalent BTK inhibitor. And we're fortunate that we have three of these available now in CLL. We have ibrutinib, we have acalabrutinib, and we have zanubrutinib. And actually with acalabrutinib, there's an approval with obinutuzumab as well, so that's an option to consider. But really the idea with BTK inhibitors in the frontline setting is that we use them as a continuous therapy until time of progression or an unacceptable toxicity. And most of our patients do tolerate these drugs well and can stay on them for many years with excellent efficacy. But we do also have a time-limited treatment option with venetoclax plus obinutuzumab. It's a little bit more intensive to get started on this treatment. It involves the infusional component and then the careful monitoring for tumor lysis syndrome with the venetoclax in the first couple of months. But at the end of the 1 year of treatment, patients go into remission most of the time and can have a durable remission often for several years without the need for ongoing treatment. And then I'll just highlight that coming soon in the near future, we're going to likely have a combination of one of the BTK inhibitors, probably acalabrutinib, with venetoclax. And this is going to be a time-limited regimen without the need for an infusional component. So it'll be an all-oral regimen and probably about 14 months long, and will be a nice option also to consider for those patients who like time-limited therapy, but maybe don't like the idea of the infusional component. Now, one thing maybe if I could ask you, Lindsey, to comment on is we talked about the molecular profiling in the first part. So how does that influence your thinking about these different choices?
Absolutely. So there are a couple of things here. The first is these really are just different regimens, right? A continuous oral pill versus time-limited therapy that, like you said, has some logistical considerations are two different strategies. They have not been compared head to head, and I think that's an important piece to highlight, that in our current practice landscape, we do not have data saying that BTK inhibitors versus venetoclax or obinutuzumab, one leads to better outcomes. So a lot of what we've done up to this point is relying on patient comorbidities, meaning what other medical problems do they have? Is one of these options truly better than the other? And then also patient preference. There are patients who don't at all mind the idea of an additional pill a couple times a day, and there are patients who really are opposed to that idea and really would prefer time-limited regimen. So I think that in the current landscape, that really has been a consideration. Looking at patients with higher risk disease features, so those with TP53 aberrations, either deletion of 17p or a TP53 mutation, the data are probably strongest for continuous BTK inhibitors. We've had, kind of longer term outcomes looking at patients with TP53 aberrations and seeing that patients do really, really well with these continuous BTK inhibitors. This number of patients that were included in the venetoclax and obinutuzumab study who had TP53 aberrations was relatively limited, and those patients had a shorter progression-free survival when compared to those who didn't. Now, you're kind of comparing apples to oranges, right? Continuous drug versus time-limited therapy. And if a patient with TP53 aberration at some point is going to have a venetoclax-based regimen, one could make the argument that maybe doing that up front might give you the best shot at time-limited therapy. But that's obviously a point that a lot of people debate. And I think until we have head-to-head data, we're really not going to know which of those approaches really is better. So right now, a lot of it does depend on patient preference and as well as comorbidities. Is that kind of how you think about it? Or do you have a different approach?
No, that's very similar to how I think about it. I mean, I think the other key piece of missing data right now in that question is how effective is venetoclax obinutuzumab when given a second time as a retreatment strategy? Because you can imagine, even though the initial PFS might be shorter with ven-obin in a high-risk patient, that if you could give it a couple of times, that it may end up being similar to a continuous BTK inhibitor, but with a lot less treatment because it's a time-limited therapy. So that's really one of the key questions that we're trying to answer now in clinical trials. But I agree with you, until we have that piece of data, then we really probably should prioritize continuous BTK inhibitors for the high-risk patients. That being said, if I have a high-risk patient who has some very serious cardiovascular comorbidities, maybe they're already on anticoagulation, these are some of the factors that might tip me toward using venetoclax obinutuzumab, even in the high-risk patient, because if they run into trouble with a BTK inhibitor early on, then we really haven't done a service to the patient. So, it's kind of complex as you kind of intertwine all these different factors, a lot of the ones you mentioned in terms of patient preference and comorbidities, and then the genetic factors. So really allows us to individualize the optimal treatment for individual patients.
And I think the addition of a BTK inhibitor plus venetoclax-based regimen into the mix is going to, at least for some time, make it even a little bit more complex rather than simpler. I know, so we had some data come out last year in terms of looking at BTK inhibitor plus venetoclax regimens and who are the patients, when patients are progressing after these regimens, what is effective afterward. Matt, can you take us through that data a little bit? Because I think that's informative as we're figuring out the role of these regimens in early lines of therapy.
Sure. I think this is a key question around the resistance because, one of the common questions I've gotten when I've talked about BTK plus venetoclax regimens is, hey, you're using your two best mechanisms first. What are you going to do when patients progress? So what we've seen so far is that nearly all patients will go into an excellent remission with BTK plus ven-based regimens. And a good example of that is the Captivate study, where patients were treated with ibrutinib plus venetoclax for a fixed duration in one of the cohorts for 15 months, and then went into remission, about 70% of the patients still in remission around 5 years of follow-up. And one of the things that was interesting that emerged from the ASH meeting this past year is that in the relatively small number of patients who did recur and required treatment, they responded well to either BTK inhibitor as monotherapy or to BTK plus ven again, so getting the same regimen a second time. Response rates were in the range of about 85%. We don't know yet as much about the durability of those remissions, but it certainly looks promising that even if we use our two best mechanisms first, as long as we do it in a time-limited way, we're not going to see the emergence of resistance resistance mutations arising. And this has also been reported in a separate publication where they took the patients who progressed on the Captivate study and they sequenced them for the mutations we'll talk about in BTK as well as BCL2 mutations, which could confer venetoclax resistance. And they did not see any mutations in these patients who had recurrent disease after time-limited BTK plus venetoclax. So I'm very optimistic about retreatment approaches in CLL, and I think the whole profile of resistance is going to be very different from what we'll talk about shortly, which is resistance to continuous covalent BTKI.
Awesome. So I think what we're, really talking about here is how effective these frontline regimens are. And we have continuous therapies, we have time-limited therapies. We're on the brink of having even more options. But when you are thinking about a BTK inhibitor and really looking at that as the frontline regimen for a patient, either because that's their preference or their comorbidities suggest that that's really the best strategy for them, how do you think about the BTK inhibitors that we have approved in the frontline? And are there differences in how safe these drugs are that make you reach one direction or another?
So, we've had ibrutinib now for over 10 years in CLL. We have a lot of experience with the drug. It's really the drug that revolutionized the treatment of CLL. And so I give a lot of credit to the developers of ibrutinib for really helping to revolutionize the field. But that being said, we've known for a while now that there are some significant cardiovascular issues with ibrutinib, particularly dysrhythmias, hypertension, even ventricular dysrhythmias in some cases. And so for a while now, we've had a sense that the more selective newer BTK inhibitors like acalabrutinib and zanubrutinib have a more favorable safety profile than ibrutinib. And now over the last couple of years, we've actually had 2 head-to-head studies that have read out that have directly compared these strategies. So the Elevate-RR study compared ibrutinib to acalabrutinib directly in the relapse setting, 1-to-1 randomization. And the Alpine study was very similar, comparing zanubrutinib to ibrutinib. And both of these studies showed significant safety advantages of the newer, more selective BTK inhibitor over ibrutinib, again, particularly when it comes to cardiovascular toxicities. But I think it's really impactful also to look at things like discontinuation rates, dose reductions, and these all tended to favor the newer BTK inhibitor. So from these direct studies, I think it's pretty clear that we should be using either acalabrutinib or zanubrutinib for our patients. I think the challenge comes in that we don't have a direct comparison of acalabrutinib and zanubrutinib. And so maybe I could put that one back to you and just maybe kind of expand on how you think about the differences between those 2 drugs.
Yeah. So these head-to-head comparisons were done in the relapse refractory setting and are different patient populations. So I think it's really easy when you have, an A to B comparison and an A to C comparison to then take those data and say, okay, well, let's compare B and C. But I think there were some structural differences in those studies that makes that comparison faulty, right? So when I'm thinking about the profiles of these drugs, we, saw slightly different rates of atrial fibrillation. We saw that hypertension was maybe a little bit different between these agents. But I don't think that we can really utilize these data to fully say, okay, because this was better in one study than it looked in the other, we really should extrapolate to say that's a head-to-head comparison. And in order to overcome that limitation, there have been a lot of these studies called MIACs. So it's kind of an indirect comparison, and it's using mathematical modeling and some manipulation of the data to make them more comparable. Now, there have been conflicting MIACs, which is always a little bit challenging, depending on which data set we use to say that either zanubrutinib is better than acalabrutinib or acalabrutinib is better than zanubrutinib. In clinical practice, I'm really looking at the patient in front of me and kind of what I anticipate they would tolerate better from a side effect profile. So there are some subtle differences that do kind of differentiate these agents. And those tend to be kind of the features that I rely on more heavily. But how do you think about kind of these indirect comparison data?
Yeah, I agree. I mean, I've been involved with some of these analyses, and I do think they have some value because otherwise, if we don't use these systematic ways to compare across the studies, we're just going to compare ourselves anyway. And so, there is some logic to how the MIACs are developed. You're right that there's been some conflicting results. To me, that suggests that these drugs are probably more similar than they are different. That we do see in practice, some of the things that have emerged. For example, acalabrutinib does seem to have a higher risk of headaches. So if I have a patient who's known to have migraine headaches and we're trying to choose between a BTK inhibitor, I tend to lean towards zanubrutinib. On the other hand, it seems like acalabrutinib has a little bit of a lower risk of hypertension, whereas at least in the Alpine study, zanubrutinib had a similar risk of hypertension as ibrutinib. So if I have a patient already struggling with hypertension and I have to put them on a BTK inhibitor, all other things being equal, I kind of lean toward acalabrutinib. So, there's some of these subtle things that point us one way or the other, but I think they're both great drugs. It's great to have these options. I would say, right now we do have longer follow-up with acalabrutinib in the frontline setting, which makes me a little more comfortable using that drug in that setting, whereas in the relapse setting with zanubrutinib, in addition to the improved safety profile over ibrutinib, zanubrutinib did have an improved efficacy profile over ibrutinib, which I find intriguing. So I find myself using more zanubrutinib now in the relapse setting. And I think as these data sets continue to evolve, those preferences may change, but that's sort of how I'm thinking about it now.
Now let's delve into the idea of BTK inhibitor resistance. So if you have a patient where you've started a continuous BTK inhibitor in the frontline setting and now their disease is starting to demonstrate evidence of relapse, how are you thinking about resistance in this setting? What kind of testing do you do?
So the first thing I would say is that it's very unlikely to have completely de novo resistance to a BTK inhibitor. In other words, sort of like a primary refractory patient, especially in the frontline setting. I can't say I've never seen it, but maybe once or twice in the many dozens or even 100 patients or so that I've treated in this setting. So I think if you're seeing some kind of resistance, primary resistance to a BTK inhibitor, you want to start thinking about other possibilities. Could this be a Richter transformation, for example? Should I be getting a PET scan to look for something else? Because it's just incredibly uncommon to see primary resistance to a BTK inhibitor. A lot of that I think is because we don't tend to see the resistance mutations emerging on BTK inhibitors until much later. We don't think they're necessarily there at baseline, although that's a little bit controversial about whether there may be some mutations that are selected out. But my hunch is that these are resistance mutations that occur in patients on the drug and develop on the drug in the majority of cases. And so it's really not necessary to test for BTK mutation prior to starting treatment. You can assume that there's no BTK mutations that are clinically meaningful, at least. So I think the question comes up of sort of when to test for resistance in a patient who's doing well on a BTK inhibitor and then maybe starting to show some early signs of progression. And that's sort of the framework of how I think about it. So, most cases, patients will do well for several years. And then often it'll be the lymphocyte counts starting to rise a bit, and they're feeling fine otherwise, or maybe they're having some lymph node growth, even if the counts haven't changed too much. That's a scenario where I do like to test for a BTK mutation, not so much because I'm necessarily going to change therapy right away, but it does kind of help kind of provide early warning that I'm going to need to think about other options. And one other thing to mention is that there are some differences in terms of the activity of the covalent BTK inhibitors against various mutations. And for example, in patients who develop the C481S BTK mutation, they can do well for a period of time on ibrutinib. The median in some of the studies is around 9 months from time of detection of the mutation until time of actual clinical progression. Interestingly, with acalabrutinib, it has a lot less activity against C481S BTK. And this has been my clinical experience as well. I'm not sure if it has for you as well, but just those patients who start to progress on acalabrutinib with a BTK C481 mutation tend to progress fairly rapidly and need to switch treatments pretty quickly. Is that something you've observed as well?
Yeah, absolutely. And I think that, the classic teaching is if you're progressing on one of the covalent BTK inhibitors, that should confer across resistance across the class, which is a rule of thumb, I think is a fair rule, right? If you expecting that you're going to have a durable response to a different covalent BTK inhibitor if they've developed progressive disease on one, probably is not a realistic expectation. But like you said, these drugs have different ability to bind to different mutations. So I think that is an interesting piece. And for this patient who's been on drug for a while and is showing this, rising lymphocyte count or slight nodal growth, what is the actual test you're sending? Like, let's talk about the mechanics of testing for resistance. How do you do that?
Yeah, so for us, we do have an in-house NGS-based panel that's sequencing actually about 90 genes or so, and one of those genes is BTK. Another one is PLC gamma 2, which is another mutation that can occur in this context that we think confers resistance. And so for us, it's our internal panel, but there are commercially available panels that can be sent. So if that's not something you have access to yet in your practice, I think it is worth looking into of how you can do that. And again, I think it can be informative in terms of understanding, why patients may be developing resistance. That being said, and we may kind of get to this, I don't know at this point that it necessarily influences my choice of next line of therapy, depending on whether there's a mutation there or not. I'm not sure if that's the case for you, Lindsey.
No, I totally agree with you. We're also learning more and more about what mutations are arising in different contexts. So the mutation that we've known about for the longest is the CIS481 mutation. And CIS481 in BTK is the attachment, the covalent binding site for the covalent inhibitors. So, when I'm talking to patients about this, I use a key analogy and I say, in order for this key to work on your BTK, your lock needs to have a certain conformation. And if your BTK changes the conformation of your lock, all of a sudden your key doesn't work. And I think that that's really the mutation that we understood first. That's one that just makes intuitive sense. We're also learning more and more about how other mutations can develop even with covalent BTK inhibitors. And a lot of that work has been kind of inspired by the idea that, and this is jumping ahead a little bit, with non-covalent BTK inhibitors, we've found these additional mutations. And now that we're looking kind of backward toward what's happening with the covalent BTK inhibitors, we're learning that mutations can develop not just at the site of covalent binding, but also in other parts of BTK.
Yeah, absolutely. So since you brought up the idea of non-covalent inhibitors, why don't we transition a little bit into sort of the second part of our conversation around sort of second line and later lines of therapy. We've started a patient on a covalent BTK inhibitor. They're starting to progress. Let's say we send mutation testing and there is one of the mutations we discussed that's present. So what are the treatment options now to help overcome resistance to first line BTK inhibitors? And how do you think about using them?
After a frontline BTK inhibitor, the FDA-approved regimen is a venetoclax-based one. So Murano was the combination of venetoclax and rituximab in the relapse refractory setting as a 2-year fixed duration therapy. It's worth noting that that study included few patients who had had a prior covalent BTK inhibitor. So this has been up to this point a relatively understudied group of people, because just based on when these studies were done, not that many patients had had a prior covalent BTK inhibitor or had developed resistance to a prior covalent BTK inhibitor. But we do know that there is activity of venetoclax in patients who have progressed on covalent BTK inhibitors. We see that in clinical practice. We have retrospective data suggesting that that's the case. And in the relapse refractory setting, we could, have an argument to be said that perhaps obinutuzumab is also a better antibody to pair with venetoclax. But Ven-based regimens do have activity even when covalent BTK inhibitors have been used and patients have developed resistance. We also have the FDA-approved option of pirtobrutinib, which is the non-covalent BTK inhibitor. Notably, that's approved for patients who have had 2 prior lines of therapy. So that approval really is kind of looking in that double exposed patient population. And so often my second line of treatment based on the approvals is a venetoclax-based strategy. Is that how you're thinking about it, or anything to add to that piece?
Yeah, that typically is how I've thought about it. I think it is challenging, as you highlight, that we really don't have good prospective trial data to understand what type of venetoclax-based regimen to use in the post-covalent BTK inhibitor space. We also had some data with continuous venetoclax therapy in that setting, but that was from a trial of patients with median of 4 prior lines of therapy, which was mostly chemoimmunotherapy. So that really doesn't apply too much to a second-line post-covalent BTKI patient either. So I've found in my practice that in the absence of compelling data, I put together what I think is probably the most effective regimen, kind of extrapolating from other studies, which is a combination of venetoclax with obinutuzumab. And instead of doing the 1 year of venetoclax like we do in the frontline setting, I'll often use 2 years of venetoclax in this relapse setting, extrapolating from that Murano data set that maybe the second year is helpful, but we really don't know. I think the potential to use pirtobrutinib in the second-line setting is intriguing. It did get a listing there in the NCCN guidelines, even though, as you point out, it's not technically approved there. So that would be an off-label use of second-line pirtobrutinib. But you can imagine, and I've encountered this situation, patients who really like the idea of the convenience of a continuous BTK inhibitor in the frontline setting, and they like the idea of staying in the class and staying with a BTK inhibitor and not complicating things with venetoclax and antibodies in that second line setting. So I think that is a nice option to have pirtobrutinib available there. So, we're seeing more and more pirtobrutinib being used now, either in the third line or beyond, but now also in the second line setting. And I think one of the things that's been interesting is we've seen yet a different pattern of resistance mutations arising on pirtobrutinib. And I know this is something you guys have also been involved with at Memorial Sloan Kettering. So maybe take us through a little bit about how resistance develops on non-covalent BTKI.
The discovery in the space has been interesting, right? We had these patients who were on the phase 1/2 study of pirtobrutinib that led to the FDA approval of this agent. And with progression on pirtobrutinib, this new pattern of BTK mutations has emerged. So there are a couple of different ones that we think about. So there are gatekeeper mutations, which are the mutations that kind of block the drug from accessing the pocket where it binds. So rather than impacting how that we talked about, the lock in BTK changes conformation and you can't get the lock in. Here it's like there's a cap over the lock, so you can't even get your key near the lock to try to make it work. So that's a gatekeeper mutation. And then we're also seeing this idea of, kinase dead mutations, suggesting that BTK, right, is a kinase in our cells, and it's allowing for signaling by creating kind of this chemical conversion through the kinase. There are mutations that actually take away that activity. So the kinase is not working. You're not getting those chemical reactions in BTK, yet you're still seeing downstream activation, meaning that the other pieces of the other parts of signaling are still happening. And we think that that's because BTK, in addition to having kinase activity, meaning this kind of chemical reaction activity, also has scaffolding activity, which means it's sort of like a platform where other proteins can assemble and allow for signaling as sort of a platform. So we're seeing both of these types of mutations pop up on pirtobrutinib. I think the interesting piece is that now looking backward, we're learning more that some of these mutations might actually also be occurring with covalent BTK inhibitors. So can you tell us a little bit about that, Matt?
Yeah, I think that's really an interesting recent finding. We just saw a publication on the resistance mutation profile of the patients on that ELEVATE-RR study of ibrutinib versus acalabrutinib. And although BTK C481S mutations were the most common, they also saw in that study a significant proportion of the patients progressing on acalabrutinib with that gatekeeper T474 mutation, which was pretty surprising and a little bit concerning in terms of whether those patients would then respond to pirtobrutinib, since that's one of the mutations that seems to confer resistance to pirtobrutinib. So, I think there's certainly plenty of patients on that Bruin study who had progressed on acalabrutinib who did respond to pirtobrutinib. So that aspect is reassuring. But the other one that's come up is also seeing L528W, that's the kinase dead or kinase impaired mutation. And that's even been reported in patients on zanubrutinib, again, kind of raising this question of whether those patients would respond to pirtobrutinib. So I think it really highlights that there's a lot we need to learn here still. One thing that I think is a really interesting development in the field is a whole new class of BTK inhibitors called BTK degraders. And as we kind of talk about how we might manage our patients who are progressing on a non-covalent BTK inhibitor, that's really one that comes to mind.
Yeah, so BTK degraders are this new class of drugs, and there are a couple in clinical development where the idea is that the drug is going in and actually getting rid of the protein. So rather than just inhibiting it or changing its conformation so that it's not working as a platform, it's just gone. These are drugs that, based on our early looks at efficacy and safety, seem to be really effective and well tolerated even after patients have progressed on prior BTK inhibitors, covalent and non-covalent. So we're seeing activity there. And I think it's going to be an important class of agents moving forward. I think the other piece to think about is what implications these findings are going to have on sequencing, because as we were talking about, we don't have a ton of data to say sequence ABC is significantly better than ACB or BC, whatever iteration you want to use. And I think that thinking about how resistance developing on your current line of therapy might confer resistance to a future line of therapy, and whether any intervention in the middle might actually impact that. So if you've developed a resistance mutation on a covalent BTK inhibitor, but then you switch gears and use venetoclax, does that actually get rid of, the clone that had that mutation develop? And those are data that we just don't have and we don't know, but I think it is an interesting hypothesis and demonstrate, kind of highlights how much we need to learn in this space.
Yeah, I agree. I would say my hunch is that venetoclax is not going to completely eradicate a BTK mutant clone. We've certainly seen data suggesting it can decrease the VAF and even make it to the point where it's not detectable. But unless venetoclax is hypothesized to actually cure the CLL, my suspicion is that it's going to come back at some point. And that's okay. We have a lot of options now to treat these patients. I would say it is also interesting that with the BTK degraders, we've already now just recently seen the first report of a resistance mutation to one of those degraders, which is an A428D mutation in BTK, which has also been seen with some of the other BTK inhibitors. So I think that's interesting as well. The BTK degraders are probably going to have their own pattern of resistance that develops, but as you suggest, potentially rotating around these drugs may continue to kind of buy time as we wait for additional mechanisms to be developed. And maybe that's a good place to kind of start to wrap up as we think about the future of CLL therapy, because probably eventually some patients will move through all these lines of BTK inhibitor-based therapies and venetoclax. And one of the intriguing developments in the field over the last couple of years has been the development of immune-based therapies in CLL. I thought I might never see it, given that the immune system is defunct in CLL, and here we are relying on the immune system. But there's a couple of different approaches that have been kind of promising over the last couple of years. So maybe you could talk about those.
Yeah, so recently had the FDA approval of CAR T therapy, and I think that there is work to be done in that space, right? The overall response rate to CAR T in CLL is low, but we do see that the patients who achieve responses do have durable responses. So I think that will be a strategy that is important for the field and particularly for a subset of patients who have higher risk disease. But I think that we're going to figure out how to use them better and better with time. So that's CAR T. We also have bispecific T-cell engagers, which have shown great activity in other lymphomas, and we're learning about how to utilize these in CLL. So there are ongoing studies looking at bispecific T-cell engagers in CLL, both as monotherapies and in combinations with other agents. And I think that we'll be able to see kind of how these add in as well. And then there are other inhibitors that are also in development. So maybe not as immune-based, but we have, additional targets in the B-cell receptor pathway that are being studied as well. So this is a field with a lot of current options that are incredibly effective, a lot of emerging options. And I think that the future is bright for our patients and for the care of this disease.
Yeah, I think that's a great summary, and I fully agree. It's been an exciting time in CLL research over the last couple of decades. I think it's going to continue to be so in the next decade and beyond. And hopefully our conversation today has been helpful to allow the audience to have a deeper understanding of BTK inhibitor resistance in CLL, so that people can better manage their patients with this disease. So thanks everyone for tuning in, and we hope you'll join us for another program soon.
Thank you, Dr. Davids and Dr. Roeker. And thanks to you, the listener, for joining us. As a reminder, to view the full program, A Cancer Conversation, Optimizing the Care of Patients with CLL Through a Deeper Understanding of BTK Inhibitor Resistance, and to download educational materials associated with this discussion, please click on the link in the show notes. Thanks for listening.